So we will have folks running around with microphones, so just make sure to raise your hand if you have questions. But I thought I would just maybe get us started with a question, because I feel like we've had so much great information here today, and we have such a great panel of experts. And I still feel kind of overwhelmed with how to address this issue. So I would love to hear from each of you. There's so much response at the national, state, and local levels to try and address this opioid crisis. What do you all see as things that are working or not working, and why?
I think that there is a lot that is working, and today is a clear demonstration of that. I'm not sure how many people are in the room right now, but this is evidence that what we're doing is working and we're getting better. In my personal opinion, I think that we need as many treatment options as we have people who are suffering. And I think that we need to be open to everything. Nothing is what did you say earlier, Dr. Malec? Always and never should not be part of the discussion. So I think that we're getting better. That's my opinion.
So I think that because this is a complex problem and it requires a lot of people working together in the solution, we have to keep reaching out, because I think we get the best results when we have more than one person at the table. And I think that's been clearly demonstrated in the talks. But I think from a clinician and very local perspective, I do think that feeding back information to providers about successes, like kind of telling people, guiding them towards this is what we want you to do, and then showing them how they're being successful doing it is a very good means of getting those things done within sort of local institutions. So letting them know that they're successful when it's happening, I think we have to make sure that we feed that information back to keep it going.
I was traveling. I was up in visiting some tribes up in Michigan, and we were at a task force meeting, and this individual came in, and they had baked a cake. They baked a cake, they put it in the back of the room. And the person said, I don't know anything about opioids or substance use, but I want to be part of the solution to my community. I know that people are affected by it. And I remember, they used to talk about addictions and mental illness as the no casserole sort of diseases. And I think what I'm seeing is a change in stigma. I'm seeing a change in the conversation. And with that brings me great hope, regardless of the continuum, whether it's youth or older adults, that we're starting to see these changes in society. And that's opening up, a lot of different sort of partnerships, conversations, from justice to treatment to public health, aging, et cetera. So I'm starting to see that arc turn.
Great, thank you. Questions in the audience? Raise them up high. I've got a couple over here.
Hi. First of all, I want to say that all of you did a wonderful job. I'm wondering what progress you've made in including the legal system or the criminal justice system into this whole process, rather than offering treatment versus criminalizing, incarcerating people. So have you been invited to any of those type of forums?
Absolutely, here. Prior to working as an independent consultant, I spent a total of 15 years working for a couple of pharmaceutical companies. One of them was the makers of Narcan nasal spray. And so I had about 13 states that I was responsible for. And so I had the privilege of training close to 1,000 law enforcement professionals across the U.S. And one of the things that I learned about them in particular is that they for the first time ever, they have had to become healthcare professionals, and they're not used to that. So one of the things that we can do to help them to make that shift is to teach them about the disease of addiction. Now that they're faced with it, and in many states they have to carry Narcan, they want to know more. So I want to encourage all of you, or any of you, to stop by your local police department and tell them what you know and why it's important. There are also a lot of diversion programs that are happening across the U.S. In Illinois specifically, Lake County has done a great job, DuPage, Kane, and even a few in Cook so far. So what they're doing is they're routing people to treatment versus jail. And so I'm definitely seeing an increase in positive solutions toward recovery planning versus jail.
I'd agree on that, and I think what we're seeing is this partnership, and I think I've seen good examples of response teams where law enforcement has gone out with like a recovery coach or some other type of addiction professional engaging families and trying to make sure they're in the right setting. I think that the place I've seen this most is building that trust and recognizing, what is the real problem we're trying to solve and what are the levers that we have available across the system of public health and public safety, because it's going to have to be a partnership. When public safety is the number one referral to the addiction treatment center, we've got to do something together. So I think I'm seeing some promising practices, like you mentioned, a lot of the diversion programs really unfold. And I think also in the court system. So we have law enforcement, and then we have the court system. We're trying to see more drug courts that are being promoted, and also sort of the awareness in other courts, family courts, common pleas courts, that not everyone, if you think of a drug court almost as a specialty provider, there's all these other courts that have addictions that are involved with them. So I think it's an opportunity for us to be educating some more of the other parts of the judicial branch in terms of, how we can help this family. So I've seen some encouraging progress in that, but it's going to start with trust. And I think that's something, depending upon where the community is, that's going to have to be a place that they get those conversations together.
As a service provider in the Chicagoland area, it's been very difficult for me to find treatment opportunities for individuals, especially who have Medicaid and Medicare. So what are some suggestions that you have? The wait lists are extremely long, and we have a brief time to place them, especially if they're in an acute, psych unit or on a medical stabilization unit. And I know a lot of the time we've been referring them out to like MAT in the community, but sometimes individuals need more support than daily dosing or that once monthly check-in with a psychiatrist. So what services are specific to this population in the Chicagoland area?
Yeah. Well, I was going to ask if there's anyone from the state here who can help sort of talk about their hotline or other sort of initiatives that they have to place individuals. Yeah. You're probably best equipped
great.
to answer.
Thank you, James.
Hey, I'll just say real quick, the Illinois Helpline is one of the resources. We have cards over at the desk, helplineillinois.org. I don't have the phone number memorized off the top of my head, but it's in my presentation. That's the best resource. They have a call center, and they'll talk you through if you're looking for any. Yeah, that's the card right there. It's the purple one. But they'll talk you through any specific resources you're looking for. So if you're looking specifically for medication, or if you're looking for counseling, or if you're looking, and then special populations as well. So they can kind of help narrow that down as well. And I think also by funding source. So I'll pass it back to Captain Coady to talk about increased funding for treatment services.
You learn as a Fed never to talk about anything local or state, but no, I mean, I think it's a challenge. But I think what we need to be looking at is the different type of modalities. We do have a workforce challenge, and I think that we've sort of heard here that, how do we increase capacity, be it primary care in terms of our federally qualified health centers, both our specialty care providers. How do we look at, the role of telehealth, the role of technology and applications? I mean, I think we have to look at all the different levers that we have that could be available to people. What is the role in terms of recovery coaches, recovery organizations, that we begin wrapping around people? I think that, yeah, there might be some bottlenecks in some places, but is there things that we can do in the interim, leveraging these different modalities that are going to help meet the need? So I think that's what we're seeing some communities move forward with, and we're also seeing a lot of increase in the data waiver. I mean, I know that there's some really significant efforts in terms of existing providers, in terms of being able to provide treatment, as well as looking further upstream in terms of the future generations of physicians and nurse practitioners and such. So.
Yeah, like the
Yeah, there's some really, really good data. I know the state has their opioid response advisory committee that puts out some really good information in terms of what they've done with that. I'd highly encourage you to review it. It's very promising.
Somewhere on the continuum or within the gray area between harm reduction for substance abuse and addiction and actual therapeutic benefits to treating opioid addiction and pain management. Do you have any points of view you could share on the use of medical marijuana, which is already legal in the state of Illinois, and now with the current governor, it's going to be legal recreationally very soon anyway. But I was just curious. I thought there might be some talk about that. Thank you.
It's like you were planted.
It's like you were.
It's like you were planted in the audience. So, I don't know. Anyone who's ever worked with me in my office knows that on a daily basis, people ask me about medical cannabis. Every day, all the time. I think that, one, medical evidence, decidedly lagging demand. Wildly lagging demand. And I think the idea that, I think that honestly, this is one of those places where people are looking for this easy fix to this problem, and there is no easy fix to this problem. And I have a lot of people come in and they want to use this. It's natural. What's out there right now? So not natural. This is not 1970s backyard pot. And so I think that, I actually think it's just not the answer. There's not, the studies that have been done don't really show that it reduces the amount of opioid taken. It's usually used in addition to and not in place of. And so I don't see it as the answer that everyone would really like it to be. So that's my opinion.
No, I agree. I couldn't have said that better.
No, I think it was well said. I do. And I think that, in addition to medical marijuana, I think we have the conversation about kratom and other alleged solutions where we don't have the evidence base, and they're very dangerous. So I think, in terms of we have the evidence base behind it, I think we need to be consistent in our messaging related to, at least in terms of addictions, medication-assisted treatment, and what we have the evidence behind it. So I think that's something we really got to be mindful about in talking to our clients about some of these other sort of anecdotal interventions that we really don't have the evidence base behind.
Some of the best evidence the best research, let's say, that's being done is actually coming out of Israel, where someone behind the times, partly because of the stigmatization, of cannabis within the overall, drug culture context. But the thing is also with the medical aspects of it, the dispensaries are held to actually extremely high standards in terms of the purity of the various products, is my understanding. They have to be. It is so tightly regulated to the extent that it's medically approved that it's literally a growing field. And there is, I'm sure increasing evidence to support some benefit. But I'm going to quit while I'm ahead. Thank you.
So that is a widely held point of view, but the evidence is really lagging, and I think that So the other thing I would say is this is it's a hundreds of millions, if not billion-dollar industry, and it is also a cash-only business. And so, and the medical evidence we have is actually for pharmaceutical products, not really cannabis. So any medical evidence we have does not really translate to what people get at a dispensary. And we don't have the evidence. We don't have the evidence like we do for any other medication to say, take this drug at this concentration, at this frequency for this problem. So we really are just sending people to a dispensary, where I would prefer they get it from a dispensary than the street, because then at least they do have some idea of what they're getting, although that is questionable, because when dispensaries have been tested, it has not actually been quite as exact as we would like to believe it to be. So I just don't, the evidence, even because there are analyses that are done of sort of world literature on this, and the quality and the number of people it really, from a perspective of really being able to recommend it very specifically, we really just don't have the evidence for it. Personally, I don't stand in the way of people getting it. I try to make sure that I talk to them about potential risks, because it's been touted as very risk-free, and it's not. And we're starting to see increasing numbers of reports of deaths actually attributable to cannabis, where before it was always like there are 0 overdose deaths from cannabis, look at that compared to opioids. Now we're actually seeing that there are consequences to cannabis, so it's not just purely safe. And a lot of that is because of the concentrations of drug that are now available, where high-dose marijuana used to be 10% THC. That was the highest dose that NIDA grew. And NIDA has a pot farm, in case anybody didn't know. It's at Ole Miss. And that was the only place that you could get it for research. But it was only specifically for drug abuse research. But now people are often getting concentrations that are, 60%, 50%. I mean, it's so different than what it used to be, that it's just to say that, and to say it's one thing. Medical cannabis is not one thing. It's hundreds of things. And I had a very interesting conversation with a patient yesterday who said, every time I go to the dispensary, they have different things. So I go and I try to get the same thing that worked for me last time, and they no longer have it. They have something else that they want me to buy. So that consistency, we want to believe in this. And that's, to me, that's one of the biggest things, is that there's so much emotion attached to this conversation, where people are like, I want this. This is natural. This is good. I've seen all this great stuff on the internet about it. It cures cancer. It, stamps out all disease. It'll make me happy. It'll make me sleep. And there's just not. We're just not there yet. There could be. I believe there's potential promise, but we're just not there yet to really sort of widely recommend this as any sort of real answer to this problem.
Also, just to layer in the older adults as well. I mean, if there's limited data for kind of general population, there's basically no data for older adults. So just to take it back to the context of this conversation too, I think it's even more challenging to be able to provide any accurate evidence or data to our patients, because there isn't any for older adults. All right, shall we move on, panel? I saw a question up here in the front.
I'm 66 and I've been in the field since '82, and this is the third epidemic. We had an opiate epidemic before, and then we had the crack cocaine epidemic, and now we have this epidemic that's driven by prescribed medication. The first heroin epidemic was driven by heroin in the streets. And as a kid, I grew up with that. There has been some major changes, and I'm wondering how much research did you all use in this one that you got from the past epidemics?
I defer.
I would say considerable.
Mm-hmm.
I'd say considerable because I do think that our response is different. I think the attitude is different. And I think we have better, obviously, just our research behind it is so much better, different. And I think, sort of understanding a little bit better in terms of addictions. I mean, the addiction science compared to what it was then now is far superior. I think we learned from other public health challenges like HIV and AIDS in terms of, what people need. So I think we're translating some of those experiences as well. I know that in a lot of those epidemics, there's a lot of pain, there's a lot of hurt. And I know some communities are still suffering from that and sort of lingered. But I'm hoping that as a nation, we've grown from some of those experiences and learned and trying to apply them in a more thoughtful way. And really, I think addressing some of the stigma as well. I think that's something that we've seen. So I know it's something that really, I think, informs of what we can do better. So it's something I'm quite mindful of as well. And I think that's also sort of similar to the trend of how we're seeing, now the opioids, and then we're sort of going, the stimulants, that we've been there before, in terms of that sort of equation before. So I think we're trying to learn from there as well as we better prepare for the stimulants that are here now.
Thank you very much for organizing the conference, for presentations, and for multidisciplinary approach. I like this very much. We help in affordable housing many seniors, and one of the issues that we frequently see is that they get prescriptions from different medical professionals. So what can we do to encourage, how can we be unified, better coordinated? So this is one of the questions. The other one is that in Chicago area, we have people who speak other languages than English, and when they become older, they forget the English language, even if they learned. How do you approach people who speak other languages? What do you do?
So the first one, and you said you had housing for seniors? Housing. Well, first and foremost, thank you. That is wonderful. I would love to know more about your services and your programs. I'm assuming that you may have someone on staff who serves in the role as maybe a case manager or staff person? Case social? Okay. So, all right. So the only thing that I can think of is possibly for individual residents, getting a HIPAA form signed with their healthcare professional and having their healthcare professional to check the Illinois prescription monitoring program to see where they may be getting opioids and from where, and working on a collaborative plan to reduce the possibility that they get in trouble with those medications. That's my opinion on that.
I think as far as working with people who don't speak English, what we're limited to is medical interpreters. And there are multiple different options that we have for medical interpretation, from phone services to in-person services to some web-based services as well. So we do have a lot of opportunity for that. I can't pretend it's not an impediment to have a third party talking back and forth, but I think particularly, so my field is end-of-life care, so we actually work with the interpreters when we're going to talk about sensitive information so that they know what it is that we're going to discuss so that they're prepared for the kind of information we're going to be giving. And I would consider it similar with this, that if we're working with through an interpreter with a patient, that we have to make sure that our interpreter is adequately versed in the kind of information that we might be sharing. And it also has to start out with the patient understanding through the interpreter that the interpreter will be there to help us communicate.
I have a question about, just taking a more kind of social work, public health perspective. So we've talked a lot about treatment, and as you've said, one of the ways that people are introduced to opioids is after a procedure. But what I want to ask about is, or just put in the conversation, is why does it persist other than biological addiction? And of course, we know about how it's proliferating in broken communities where industries have left, people are unemployed. In the case of older adults, retirement is a big risk factor that I would love to see you all add to your slides, for people to talk with their clients about the impact of retirement, not having a purpose, not threading the needle. My question is, how much of the funding and effort is going to a more holistic prevention? In other words, is any funding going to houses of worship, community centers, to build community, to support more social resources, to, so that it isn't just a medicalized approach, but more of a holistic social approach. I know that like in the past, CDC has funded houses of worship and other places like that for things like HIV prevention, to increase breast cancer screenings. Is any of that going toward opioid addiction at this point?
That was a really big question. It's kind of loaded, and I think it probably has parts for all of us. So I'll take your first part, so I still remember what you said. I think as far as like how this happens, where people get introduced after a procedure, I think educating patients about how long they should actually be needing this medication and how they should stop the medication is probably the way that we're going to stop that, and also giving them the amount of medication that we think that they need for that period of time so that they're checking in if symptoms are persisting after. But it's really setting the expectations. And I think we always sort of assumed, like, well, when they don't have pain, they won't take the pain medicine anymore. But, you know, if you give someone a prescription for antibiotics, they're like, I take this until it's gone. And now, you know, we give them a prescription for opioids for maybe longer than we think they actually should need them. And they take them until they're gone, and then they really are physically dependent on them, and then they need to, you know, and then we're off to the races. So I think, you know, on the provider side, we need to change our behavior, and we also need to do more education to patients about what to expect. And actually, the CDC guidelines has a whole patient education piece to it about what to expect, how long to take the medication, you know, how long you should be on the medication, so that, you know, questions that you should ask your provider before you go in. So I think it has to be sort of two-sided in terms of what the public expects and what they know about what they should and shouldn't be doing, and how much then we're actually reviewing that with them and then curtailing what we're providing in those instances.
I don't remember the second part, so you may have to restate that. But I think I always come back to us as healthcare professionals, especially counselors. Dr. Malec, she stated earlier how much education she received when she was in medical school, and obviously had taken it upon herself to continue her education so that she could be a valuable resource to, you know, the state and probably the nation because of the butterfly effect that good work has. But as counselors, I want to encourage, in 2000, this was right at the launch of Suboxone, and I actually worked for them as well for almost a decade. Medication-assisted treatment was really new. I had no idea what it was. All that I knew is I was dealing with a father at home who was addicted to opioids. And like many other people, he had legitimate pain that crossed over into dependence on his medication. And as a counselor, I tried to think, what do I have the ability to do? What's within my control? So I'm working with patients who are in detox, medical stabilization, who were addicted to opioids and alcohol, and then they were being discharged with opioids after receiving opioids while they were in the hospital. So they were candidates to continue their opioid use versus actually getting better. And so what I did was, every referral that we made to a physician in the community, I would go to that physician's office and I would say, I'd like to come in and educate your staff on the disease of addiction and some of the things that you can look for, some of the signs and symptoms, and how you can be a resource to the community and the patients that I refer to you. So can I come in next Thursday? It is nothing wrong with being a resource to your community and educating. We all have something that we can do. And I think that the healthcare professionals, and maybe you all can tell me if you've ever been offended by someone wanting to be helpful within your community. Start within the community that you live in. You have a legitimate reason to go in and help. You have the information. The physicians in the community, the dentists in the community, they may not have as much education as you do in this particular issue. So if you see a need, go fill it. We can't always wait for the federal government to release funding and put it in the places where we need it the most. Sometimes we just have to take the bull by the horns and get out there and go do what we know is needed, especially in our communities. And if all of us do that, I can only imagine how much of a dent we can put in this nationwide issue.
No, I think it's well said by both of you. I would just add that, so public health approach, live, work, play, worship. The funding that's going to states, 80% of it has to be used for treatment and recovery. And I think if you look at, where's the bottleneck, I mean, that bottleneck right there is partly in our treatment system in terms of expanding capacity and looking at, both the insurance, the uninsured, and, who needs it and how do we use this money to help advance that effort, as well as the recovery supports. But in terms of looking further upstream, I do think, other agencies, like, for example, SAMHSA funds drug-free communities. Many of those drug-free communities, involve, for example, many of these different sort of other stakeholders, the business community, the faith-based community, at the table. I think we've seen chambers of commerce being involved. Sometimes it's the funding that sort of initiates it. Part of it is just, hey, this is my community. I have a role and responsibility. But unless we as professionals invite them to the table, articulate what is your role and responsibility to your community, sometimes we don't translate that real well. And I think we miss opportunities. Because there are tables, I think, and you probably know, Illinois has, like 110 different sort of task force or county-level task force. Those tables are there. We just got to reach and make sure we help engage those people to get to the table to be part of the solution. There's numerous guides across, whether it's, work site, whether it's the faith-based communities that exist, but who's going to implement it and who's going to take the time? Someone's got to be a champion in there. We need to identify that champion.
All right, thank you. We have time for one last question. Someone have a microphone? In the back, okay.
Thank you so much for the presentation. It's been wonderful. But I do have a question. We talk a lot about opioids prescribed after post-op. But what about opioids that's prescribed, as a child? Say, for instance, a patient with sickle cell. So especially for you, Dr. Malec, and I'm sure you may have seen, in your expertise with oncology, but what about hematology in these patients with sickle cell disease and the stigma around the usage of opioids for pain management? So the question is, how do we prevent or assess pain for long-term use of opioids for a chronic illness that is centered around pain?
So I think that we have to have sort of chronic checking in. There are screening tools for opioid misuse, and I think we have to be in constant communication about how the medications are used and what they're used for, and the idea that, the purpose of these medications is not, because truly, certainly with a disease like sickle cell, for many patients, there is no day without pain. No matter how much opioid you're taking, you have pain. And so trying to make functional targets and have individualized plans and have a team of providers who are helping you cope is the important thing. I think for sickle cell, very specifically, this is one of our most difficult problems. And one of the reasons it's so difficult is because it's very under-resourced. So, and in any given institution, with very few exceptions, there aren't enough providers, there aren't enough medical providers, because it's a difficult disease process to help treat. It's often an under-resourced population, and there's so much. It's multi-layered problems. And I also think that we need better research on the type of treatments that would best manage the pain in this disease process, because I don't personally think that opioids they're the answer we have, but they are not a great answer, because you do see people on very high dose medications who aren't getting relief. So we know those drugs aren't working, and sometimes they're contributing to the problem by causing what we call hyperalgesia, or actually increased sensitivity to pain. And I think that's something that we see. We're trying to work on a better pain management process, but we want it to be one that doesn't feel punishing to the patients. Like, we're just taking this thing away from you that's the only thing you know to be at all helpful to you. We want to make sure that we're layering in helpful modalities, particularly during times of crisis. But I think, honestly, it's having honest, supportive communication with the patients and their families that I think is what we've got right now. That's, I think, the best that we can do right at this point with what we have.
Great. Well, thank you all for your wonderful questions. And if people have questions that we didn't have time to answer, I'm sure our panelists probably would not mind to just answer them during the break.